Alliance Nursing Home Leadership Roundtable, where we continue our series of turning your deficiencies into efficiencies. Today is all about behavioral health in the nursing home. We have a guest speaker, Dr. John Brose. My name is Constance Tetrov, and I am a Quality Improvement Advisor with Superior Health Quality Alliance, and I am accompanied by several of my colleagues, Mike Keisha Blesko and Margaret De Oliveira. And they will be assisting with monitoring the chat, answering questions, and providing you with any of the links, as well as our guest speaker today, Dr. Brose. We host these 1-hour sessions on the second and the fourth Wednesday of the month. The first half is a didactic presentation, then the remaining time will be for questions and answers. The presentation link will be dropped into the chat momentarily. Please use the chat box to share any comments, questions, and even resources during the presentation. Besides learning from our speakers, we learn from each other and our peers. Towards the end of today's event, we will also put an evaluation link in the chat that will only take 1 to 2 minutes for you to complete. We use your evaluations to help you and us give you a better experience and presentation. Please help me in welcoming all of our guests, and we look forward to sharing your knowledge and experience with us today. The floor is all yours, Dr. Brose.
All right, well, thank you. And I understand there's people from Minnesota, Michigan, and Wisconsin, and maybe other places, so welcome. My bio is at the end of the handouts. If you don't know who I am, and a brief overview, I'm a clinical psychologist by trade. I'm the owner of Associated Clinical Psychology. We have about 400 employees with about 325 clinicians. 50 of them only do nursing home or assisted living work. I started going into nursing homes in December of 1980, and I've continued to do so every day. Even during COVID, I never stopped going into nursing homes. My mission is to really be a voice for those that don't have one, and that includes the long-term care industry, staff that choose to work in the industry, and residents who end up as customers within the industry. I have a pretty good understanding of the rules and regulations. I liked when you said take your deficiencies and turn them into efficiencies, I think is what you said. And I've often looked at it that way, that in fact, I was just training the Minnesota Department of Health nursing home surveyors and the federal look-back surveyors just 3 weeks ago for about 4 hours. And it is it's a tough gig for everybody working with older adults in these buildings. The regulations are more complex. The workforce is becoming thinner. The experience within long-term, this is not just my opinion, but nationally, there's concern that many of the experienced people have left the field either to retirement, medical problem, or going into other aspects like assisted living or getting out of healthcare altogether. So I'm going to talk today about mental health issues in long-term care, which is something I've devoted my entire career to. What I think is very important to keep in mind, if you go to slide 3, whoever's changing them. Next one, please. There you go. People often ask me when I hear a problem like peer-to-peer aggression or sexual acting out, et cetera, what goes through your head? And the flow in my brain is I look at it through 3 lenses. Clinical, is it acute or chronic? And then I look at and think about regulatory realities, not regulatory fears, which many nursing home staff do. And I look at risk management. I failed to mention I do a lot of court work across the country where people are suing nursing homes, or I'm helping nursing homes defend themselves in various situations. But I like to look at things through those 3 lenses, clinical, regulatory, and risk management, to come up with a case clinical conceptualization. Some people say we have far more mental health issues now than we did, let's say 10 years ago. Well, in 1990, a study was done, and more than one actually, and the data suggested 67 to 93% of people in nursing homes have a mental health disorder. I think it has increased the number. I don't know if it's at 93, but it's not at 63. No matter what kind of facility it is, like some homes specialize in working with challenging residents, and others try to avoid them. Whatever type of facility you have, the numbers are there, and there are the silent sufferers, and then there are the acute actor-outers, throwing their food at the staff, verbally aggressive, physically aggressive. Another reality is that when I started my career, there was no such thing as assisted living. There was no such thing as memory care. It didn't exist. And there was very, 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 very little home health care. Well, now the easy ones go home with home health care. The next group goes to assisted living, and the next group ends up in skilled nursing facilities. The acuity, the number hasn't necessarily risen, but the number of people in the building that are showing pretty strong behavioral or emotional expressions of discontent or maladaptive behavior has gone up. We know that about 5% of Americans end up in a nursing home. Of that 5% that end up in a nursing home, a high percentage of them have been professional non-compliers around their diabetic care, their COPD, booze, dental care, fill in the blank. And so it is very important to keep in mind that everybody on this call today is non-compliant. We know in the general population, for instance, 76% of Americans don't take antibiotics as they're prescribed. That's why it says, even when you're feeling better, keep taking it. Because most people, 3 out of 4, stop. But when you get into the Happy Hills facility, suddenly people are commenting that you're non-compliant. Fill in the blank. Too much sugar in your coffee and you're diabetic, or pie or cake, and it goes on and on. So one of the things that I believe, and I was asked by the Minnesota Department of Health, they said to me, quote unquote, Dr. Brosi, why do you think the behavioral health of residents hasn't significantly improved under the statutes that came down that we all know as the rules of participation, where facilities are mandated at a federal and state level to improve the behavioral health of the resident, but also improve the behavioral competency of the staff? And I told them my opinion is that facilities are not thinking about protocols. I believe nursing homes do a phenomenal job with medical care. Let me give you an example about protocols. Take medications. Every building has about 1 billion pills in it, but you have protocols. One of them is a healthcare provider, physician, nurse practitioner, or PA has to order them. That's a protocol. Then you have to get it from the pharmacy. That's a protocol. And then facilities have places to store them. That's a protocol. And often that's a med cart. That's a protocol. Then there's a lock on the med cart. That's a protocol. Then there's wheels on the med cart. That's a protocol. And these days there's a computer often on top of the med cart. But when you come around to mental health issues, there's almost no protocols. And so if I were to end this talk in 60 seconds, I'd say the way to get better engagement from your families and your residents and have fewer complaints to the health department and to the ombudsman's office and to lawyers is make sure you have good clinical protocols in the mental health side of things. And you might say, well, what might that be? Well, it's starting at hiring. I believe probably 80 to 85% of problems that are experienced in a facility often have an antecedent that could have been prevented. Many facilities operate like the fire marshal. And as we all know, if you have a fire, your options are very limited. That's why facilities like yours are mandated to have the fire marshal come in annually to make sure that the fire doesn't start in the first place. Now, how does that translate into a protocol around mental health with your residents? I think if we were in an audience and I could see you and have you raise your hand or nod, is it possible to work in a nursing home and not be called, if you're overweight, a frickin' fat ass? I don't think it is. Or if you're a woman, it's almost impossible to believe that you won't get some sexual innuendo. Or if you're bald, or if you're a person of color. Like for me, I've never been called baldy. The reason is I'm not bald. I've never been called a black SOB. Well, okay, it's obvious why not. But I have been called a white honky. I have been called a rooster with my hair being spiked up. But we want to train our staff at the beginning of their employment or pre-employment. Do you have thick enough skin to work in this industry? I cannot tell you the number of times that I've been told, Dr. Brosi, we got to do something with this resident because I'm losing staff because of what they're saying to the staff. And in my mind, I'm going, well, it's good that those staff are finding different jobs. Now, I know there's a shortage, but if you understand your customer base, it doesn't bother you. And I often say what facilities should provide to their staff is an anti-personalization suit and keeping it near the time clock. And if people put it on and go to work and their feelings are still getting hurt, then guide them down to Walgreens to put on some anti-personalization salve. If you don't know where it is, it's in the back and over to the left. And if their feelings are still getting hurt with the suit and the salve, they need to find another job. We often are trying to force a square peg into a round hole. If you have a 100-bed facility, think of what we could learn from our zookeeper colleagues. When they go feed a lamb, they might even scratch its ears and they look for it in the field and they give it grain. When they go to feed a dolphin, they don't go into a field and they don't give it grain. They look for water and they give it fish. And they maybe could even pat it on the head when it swims by. But their expectations are aligned with reality about a lamb and about a dolphin. But we would also watch them when they go to feed the lions, tigers, and polar bears, that they don't walk in the cage and scratch the ears of the bear or the lion. They don't walk in any way, and they certainly don't walk in with food in their pockets. They throw it over the fence or under the fence. They know their customer. In your building, even if you cleared out everybody that's there and readmitted with a great screening, you're going to end up with about a 100-bed facility, about 20 polar bears, maybe 10 or 20 part-time polar bears, 50 or 60 more in the lamb category. Or you could say easy, moderate, or difficult in their presentation. Often, and whoever created the universe made it really easy to pick out a dolphin from a giraffe. It's very easy. A 4-year-old kid can do it. But if you have a 100-bed facility, it's easy to conclude everybody's groovy, but they're not. There are people that have had lifelong, acute, profound trauma. You have people with lifelong substance use disorder, personality disorder, mood disorder. And there are some people that maybe don't meet full criteria for those things I just mentioned. They don't play well with other people in the sandbox. They just don't. And so we have to make sure, like what I believe the most powerful medication in your building is your staff and their interactional style. And this is what makes it very difficult working with residents in nursing homes. So if you on the front end can do more training before you hire somebody, it's like if you ask somebody, they want to be a canoe guide up in northern Minnesota and say, well, how do you feel about mosquitoes? They're okay. How about tons of them biting you at the same time? How about sleeping on rocks? How about walking through brush and getting cut? Because that's the reality. And you might say, well, I don't know if that really fits with the nursing home. Okay, we can disagree. I think it does. And if you turn to page 10, please. I'm almost certain that somebody on this call has what you would call a memory care unit. In the old days, we didn't have any. And then we had dementia units or Alzheimer's units, and now they're called, as George Carlin would say, memory care. In fact, you even find banners hanging outside of buildings. Now, if you look at this slide I have up there, when somebody has dementia and they end up in a memory care unit, they have different parts of the brain that are affected: short-term memory, judgment, insight, abstract reasoning, planning, impulse control, low frustration tolerance, and long-term memory. Well, when those parts of the brain get affected, some people tend to manifest some of these things down below: pacing, disrobing, striking out, screaming, being emotionally labile, sexually acting out, poor hygiene, meaningless behavior, and relationship changes. If I owned a facility, I would no longer, at least internally, call it a memory care unit. In all of my years as a clinical psychologist working in this industry, I've never gotten a phone call that went like this: Dr. Brozzi, this is so-and-so, the DON from the Happy Hills facility. We have a person on our memory care unit with a memory problem. It's never happened. Never. What happens is people call here, in fact, 2 of them already this morning. Can you send somebody out because somebody is hitting somebody? A more accurate description for your memory care unit would be impulse control disorder unit. You're admitting people who are relatively healthy, who have a full tank of gas and a big accelerator pedal, but you look down and there's no brake pedal. All the socialization things that our parents and society taught us, most of them have gone out the window. There is no way, absolutely no way, whether you're in Michigan, Wisconsin, Minnesota, or Kansas, wherever, to have a quote unquote memory care unit and not have a stripper, screamer, people emotionally labile, acting out sexually, and on and on and on. It's impossible. But when this happens, often you'll hear staff say, we can't handle this here, which really means your competition are better than you because they can handle it. And we send them to the hospital, which is one of the most deadly things to do to an older adult with dementia. It hastens death, rather than saying, how are we going to manage them? Now, this takes me to another point. In a facility, and this is where getting our expectations aligned is really important. I've never heard a nurse ever come out of a patient's room and go, damn it, he still has diabetes. But I have heard them come out and say, he's still saying those nasty things to me. And we often will say, well, they're probably going to be saying nasty things up in heaven also. They have a lifelong pattern of doing things like this. They need health care, and once they get there, we need to figure out how to manage it, not fix it. As soon as staff move into that fix it mode, they're going to start personalizing it, and they're going to get frustrated. Now, remember, frustration is the antecedent to irritability, and frustration and irritability is the antecedent to neglect and abuse. So managing expectations as a leader is tremendously important. Some other things I like to remind people in long-term care is that in math, 2 + 2 always equals 4. Working with people, 2 + 2 never equals 4. I believe cultural diversity occurs whenever 2 or more people are gathered. So if you have a 100-bed facility, essentially you have people of 100 different religions and 100 different genders and 100 different family of origin, et cetera, et cetera, et cetera, that require us, and that's why it's called an individualized care plan. That's why it's resident-centered care. It's not global, it's resident-centered. Like, do you ever ask somebody when you're brushing their teeth, for instance, do you like the upper left as a starting point or the lower right? And you might say, why do I bring that up? Well, every person on this call starts in the same tooth every time you brush your teeth, either the front upper or lower, back here, back there. We have patterns. When you put on your pants, you have a pattern, left or right. Do we ever ask people, would you like a view of the sunset or a view of the sunrise? These type of things are really important to help people understand that all of us are different and we have different things that are important to us. So other ways to improve the mental health of your residents and help you better manage them is we need leaders with a vision. And the vision, in my opinion, should be we deal with the whole person, the spiritual, the physical, and the emotional / psychological. In doing so, it gives us a great opportunity to get to know them and try not to use a psychological term, trigger them. And that's what trauma-informed care is about. And I personally believe everybody on this call and everybody on the planet has a trauma story to tell. Some people that becomes their whole narrative throughout their life. Other people, it's more of a footnote, but everybody has trauma. And it's important to keep in mind that according to the research, one of the most traumatic events to occur to a human being is being admitted to a nursing home. We know that within 30 days, according to the research, residents have lost their personal identity and they're now described in institutional terms. That's Bob with dentures with an assist of 2 with COPD. Rather than, that's Bob, father of 2, coached baseball, was an accountant, and loved to water ski. Those are all different descriptors and more accurate at describing the person. All those things are important. Another one, as I said earlier, that I believe the most powerful medication in your building is the interaction between the staff and the resident. And let me give you an example of this. I think you would agree with me that any person, whether they're in the maintenance, dietary department, administrator, et cetera, if they saw a staff member doing pericare without gloves on, it would grab your attention right away and people would be talked to. Something you might want to think about is make sure that if you're in any type of leadership role, that you make sure your staff not only wear latex gloves for pericare, but make sure all their shift, they have on their customer service gloves. Oftentimes we'll hear staff say that resident's interrupting my work. Another way to think about that, the only reason I have work and I get paid is because that resident chose to make us their healthcare provider. Very important. If you go to page 4, please. So I've talked about leaders with a vision, talked about gloves. The other one is, what radio channel are you on? And that's really an important one. I'm not a physician because when I was younger, I didn't think I would like looking at blood, and it just gave me the willies, and I didn't like injections. I found out later that nurses do most of the work with blood and with injections, but I didn't know that at the time, so I went into psychology. But many of our staff, we need to help them to get on the radio station. I'm not talking country, jazz, or rock. I'm talking about get on the can-do channel, the channel that is very important, not only with the can-do, but the channel that gets rid of fear. How many times have you heard nurses say, my license is on the line? I hear it almost every day. And it's not true any more than it is for your dentist. But I would venture to say you've never sat in your dentist chair and he or she said, my license is on the line. Licenses are always on the line. But when I hear that, I reinterpret it to they don't know what to do and they're frightened. Fear is not a good thing to have when you're dealing with tough situations. What's good is taking a couple shots of curiosity and a couple shots of creativity. It's very important. When I first got into this industry, I kept hearing with peer-to-peer aggression, my license is on the line. So I went to the board of nursing and asked how many nurses have lost their license because of peer-to-peer aggression in a nursing home. The answer was 0. I asked again about 5 years ago, still 0. So what our responsibility is to deal with it. Nobody expects there not to be problems, but it's how you react and deal to those problems. So what radio channel do I think is best is get rid of my license is on the line and start asking ourselves, what can we do? Be on the curiosity channel, the creativity channel, and the can-do channel, and the management channel. Simultaneously, I've heard people say the health department says, well, I've been around the health department a lot in my career on a lot of projects, et cetera. And a lot of times I hear from staff, the health department says it's not true. So really make sure if somebody is saying something like that, it's not fear-based or exaggerated based. Here's another one that is demotivating to your team. I'm sure you've heard it. We've tried everything. You got to get on the channel that says we haven't tried everything. We're going to remain creative and curious and innovative, to try more things. If you haven't had the world's leading experts around the table in your home dealing with the problem you might be facing, you probably haven't tried everything. And here's another way to demotivate your team, or it's a cue. You ever heard this one? He or she has behaviors. I know you've heard that. They have behaviors. And whenever I hear that, I say to the staff, do you know blinking is a behavior? So when they make that global term, usually it means they're doing something that that staff person doesn't like. Well, just because we don't like it doesn't mean that they shouldn't be doing it. We might like them not to do it, but we aren't God, judge, and jury. We need to find ways to allow residents to have their rights, and we need to be creative in helping to overcome their resistance. That can be done with a good, and the key word here is a good psychologist or mental health professional in your building that can help you come up with strategies to help with clinical competence, regulatory compliance, and risk management, all 3 of those. I know some of you are from out of state. I don't know if you have mental health providers, but I was a consultant for 10 years with CMS, and some of the stuff I would see going on in nursing homes from people in my field, it was just unnerving. They didn't know what they were doing, and they, in my opinion, were not offering insight in how to help the team, the medical team in the building, to have better clinical outcomes, regulatory compliance, and risk management. The next part is making sure a protocol, which I was talking about earlier, how do we help people in the pre-hire and then the onboarding phase, what our vision, mission, and values are. What are they? And if we can help them on the front end, we're setting the expectations right from the beginning. The other thing that is helpful, if we look at the category says general, there is so much research and so much of my own experience in my team that customer service reduces acting out behavior and complaints significantly. I always remind people, residents never complain of dull needles, but they do complain. But what they do complain about is dull staff. So if there are administrators, DONs, director of social service on this call, thought leaders, make sure that you're doing everything in your power to put your customer service training on steroids. It helps, again, go back to my metaphor of the fire marshal, so you aren't just chasing problems and trying to react to the problem. There is a lot written about people in prison, psychiatric hospitals, in the old days state hospitals, nursing homes, any congregate living environment. There becomes a huge power differential, huge. And so when you're in a resident in a building and they're in a wheelchair or laying in bed, think about it. Most of us are standing up high. I happen to be 6 feet tall. The power differential from my head to their head is huge. And that can be unnerving to people. So we need to really make sure that we are watching our biases. For instance, somebody in your building that's a real pain in the neck, they're narcissistic, they're self-centered, demanding, never happy. They're probably that way their whole life. But they didn't order that on Amazon. Somehow they became that way. Like somebody with a drug or alcohol problem. They didn't order it on Amazon, say, hey, I want that for the rest of my life. There's a whole story there about it. And there are a lot of people that have problems, like somebody that tells the same joke over and over and over again, and let's say it's an off-color joke, and if they can find a partner that goes along with it, there's no problem. Or if they drink 6 beers a day and they find a partner that drinks 7 beers a day, there's no problem. But they get to the Happy Hills facility and now there's a problem. So all these things come into play, which makes our job very, very, very difficult. To me, after all these years, I'm still as excited, maybe even more now than I was 10 years ago, 20 years, 30 and 40 years ago, because I now see the big picture better than I did when I was younger and had less experience. The if you go to page 5 for a minute, and then in a few seconds here or minutes, I'm going to switch to question and answer. But if you go to page 5, please. I often will say there's 3 common medications in long-term care or in assisted living or a hospital. There's the chemical type that you keep in the med cart. And these medications can create a positive, neutral, or negative side effect. And I would argue that if those medications cause a negative side effect, the patient's drooling, breaks out in hives, we stop it. But we're looking, does that medication improve their glucose or their A1C or whatever it is? We're going in the right direction, it's helping. But a lot of medications we give people, it's neutral. We don't know if it's helping or not. And there's some, it's very clear there's a negative adverse effect, and we stop it. Now, the second medication is what I call environmental medications. Putting 2 people in the same room and expecting them to get along is a nutty notion. It's more appropriate to expect a homicide. Buildings are often noisy. I'll never forget, I interviewed a patient. He goes, I can't get any sleep. I go, well, why? You know, what's causing that? You know, the noise. And he closed his door and he said, just sit and wait a minute. Well, the laundry chute was right on the other side of his door. And when that thing slammed, it was very, very loud. It was causing a negative side effect in him, the environment. So there are a lot of things in our environments that contribute to behavioral expressions of people not being happy. It can be noise. Here's one. TR department has a group event with everybody close together, and now you have somebody who has to pee, and they're trying with their wheelchair to get through and they run into people. It would have been much better in that environment to have people spread out more and to have a path anticipating somebody's here is going to have to empty their bladder. I don't know who, but it's going to be somebody. And if we don't have a clear path, it increases the likelihood of somebody using their wheelchair as a quote unquote weapon. And the third is interaction, people to people. We have all gone into a store and had a salesperson come up to us and immediately were like this, didn't like them, put off by them. And it happens very quickly. And many times it is neutral. Hey, what'd you think about Bob? I don't know. I guess he's okay. And sometimes we meet somebody and very quickly we like them. We want to hire staff and we want to hold staff accountable to a standard. At worst, cause a neutral side effect and shoot for a positive. I'm sure all of you on this call in your career have known that when this particular staff person works, they rile up the inmates. We also know at least one staff member that we would call a dementia whisperer. He or she can get people to take baths or showers or do whatever that other people can't. So I'm back to that customer service and making sure your staff have customer service gloves on and that they're very much focused on how to cause, at worst, a neutral and at best, a positive outcome in the interactional style. I want to direct you to page 8, excuse me, real quick. Sometimes staff want to know, what do we do if we have a critical incident? Resident A hits resident B. The old method was you call for medication restraints, hospitalization, or discharge. In my opinion, most of those are dinosaurs. The best approach is to call an interdisciplinary team meeting and you do a root cause analysis and look at what are the antecedents? What are the potential triggers? Is this an acute or chronic problem? What's the cognitive functioning of this resident? Is mental illness involved? Is there a medical problem? UTI, electrolyte imbalance? Who should be notified? And by the way, with this maladaptive behavior, what did the resident get out of the behavior? Psychology 101, all behavior is purposeful. Sometimes it's hard to see what they got, but they usually do. And number 9 is an extremely important. What did my staff do when this occurred? What did my staff do or not do before the behavior occurred? And that's where root cause analysis. Example, I called one day. Can you hospitalize this patient? He threw a fork and it stuck in the forehead of another resident. I said, well, I'll be there this afternoon. Hang on. I got there. And I said, the first question I asked is, where did this occur? Dining room. Well, what do I know about health departments? Well, dining rooms have to be supervised. The next question I asked, what were the staff doing at that time? And what was their response? And then, who were they? And then we interviewed them and we found out for 5 minutes before the fork was thrown, the person that eventually threw the fork was being harassed by another resident, calling him a no good redskin, you're a drunken Indian, and I'm going to come over there and scalp you. There were 2 staff in the dining room. They didn't do anything. So I had to be the one to do that root cause analysis and bring it all out. Then often after you have this meeting, you ask, should we get our psychologist, therapist involved? What are we going to do environmentally? We're going to move this person to this floor, this one to that floor. And as a result of this event, what does it teach us what our staff education needs should be? What kind of program are we going to put in place to decrease the probability of that behavior happening again? And when are we going to review and troubleshoot the plan? All right. Let's see if there are any questions that people have. I know some things have been popping up.
So really quick, while we maintain regulatory compliance when it comes to addressing a resident-to-resident issue or being able to go through an ethics conversation related to if a resident has a physical or a verbal harassment to another resident, there is currently no specific protections for staff. In the acute care, they do have some protections by going to having security and being able to go through the legal process. So we know that the training is the best protection for all staff, and to be able to deal with different negative behaviors or verbal altercations that a resident may have. What we tend to miss is our dietary staff, housekeeping, maintenance, and so forth. How do we incorporate them when they have not had that clinical training of these types of behaviors?
That's a great question. Yesterday, I was out at a facility. I'd gotten a call from an administrator. I've known him for 20 years. He's new to that building. He said, "We got problems here. And will you come out and do a couple-hour training for our dietary environmental services, housekeeping, laundry, etc., that group?" I know exactly who you're talking about. And this, again, requires helping them to understand if they were working in a zoo, let's just say all they're doing is cleaning up the place, their environmental services at the zoo. This animal you can get kind of close to, this one you can't. What I often see happen is that group is exactly what you just said, have not been trained, and more importantly, held accountable, because there are buildings I go to, they have been trained. It's part of the onboarding. It'd be like if you had what do they call them, a laborer working alongside an electrician. The electrician's going to say, do not touch that wire or any wire that looks like that wire, because you could get electrocuted, get hurt, or get killed. There's not enough of that kind of thing on the front end. We also know from the research that housekeepers often know more about the resident than any other discipline in the building, particularly if they've been around a while. I like to often train them and talk about the things I talk about. There's no way to work in this environment without these things to happen. There's no way to go up in the boundary waters in northern Minnesota and not get scratched or bit by mosquitoes. It goes with the territory. Do you believe that you can handle it? And if somebody tells you no, they're probably in the wrong job. And that's one of the problems that we have. You're right. Our goal is not to train every one of your staff to be a clinical psychologist. They don't need to be. Like all of your aides are not nurses, but if they see redness on the skin, they're trained to say, bring it to a nurse. So if the staff are seeing things that happen, you already know the leader can in mind saying, if we had 100 staff, would this affect all 100 staff at the same level? And the answer is usually no. But it's affecting this person. What are we going to do to help them improve their quote unquote competency to deal with uncomfortable situations? So one of the things that I've helped some facilities do is create a video on the front end. This is what's going to likely happen. Can you handle it? And one of them, they had a phase out, that this is going to happen. And I used to run group homes in the 70s. And I'll tell you, if you want to get your ears lowered and get beat up, work with adolescents. If you went to one of these adolescent inpatient psych units or residential treatment or group homes, the names, the biceps that are about this big around and on is unnerving. It's not for everybody. So I agree with you that they don't have the clinical training, but we can do better, in my opinion, and maybe your home, you do a great job, I don't know. But really focusing on this is what you signed up for, and tell them that before it happens. Because then you can go back to, you remember that little video you watched? Let's watch it again. So it's a tough thing. And I see a lot of times facilities jumping all over the place because one dietary person has been out of shape about something. And they might be in the wrong job. Or we haven't done a good enough job of getting them up to speed so that their expectations are aligned with reality. I don't know. I know there's a lot of experts on this call. Does anybody have any ideas on that above and beyond what I said?
No, thank you for that response. I think that sometimes, especially with facilities, sometimes they are ill-equipped to take on certain things within their organization. And there was one incident where the facility did not do a proper admission review of a patient. And after 526 physical interactions with staff, from biting, kicking, hitting, and so forth, and doing a root cause analysis over a period of 2 years, it was that this was the most restrictive place for this individual, and they really needed to be in a less restrictive environment in order to not have the behaviors that they had. And so I think that the reality is that sometimes, because we are competing with how many admissions are within our facility, sometimes facilities are not doing a good enough job of that, or they don't have enough training within their facility. And knowing that neuropsych for senior population education is just not as in-depth as it needs to be within the facilities. And I just think that facilities need to be honest about that. But also, you're right, there are times where facilities or organizations need to really evaluate if those individuals are the right fit within their organization as far as staff goes too. And you do have to have a tough skin to be in this environment. But we also have to make sure that staff are equipped. So.
Well, or we move them down the road. I mean, there are people that go and become psychologists that within 2 years, they're not seeing patients anymore. They weren't equipped to be a clinician. They did all the academic work, they got licensed, but they weren't equipped. I just interviewed a physician that couldn't be a physician anymore, and she went back to school to become a licensed mental health counselor. Big drop in pay, by the way. But she couldn't handle it. So let me say this too. I'm going to give you a huge compliment. The fact that you knew the number of incidences is impressive. The fact that you held in there for 2 years, good for you. And I am an advocate for people, all people. I was in the nursing home in Minnesota when the first AIDS patient was admitted, and 50% of the staff quit work the next day. I've seen people quit because a transgender person was admitted. I'd seen them quit because a Jew was admitted, and on and on and on. And we have a legal, moral, and ethical responsibility to treat all people. That person, again, didn't order those maladaptive behaviors, and they weren't doing it as an accountant during their working years. For some reason, they were doing this. And I would argue, even if you had the best screening techniques in the world, you're still going to admit some polar bears, because some polar bears look like a lamb. Or family members say, oh, that's just mom, she's kind of finicky. They don't say she's got OCD, And so I'm impressed that you did it. Now, if I were involved, let's say this is week 1, I would hope these are the type of cases I've spent my whole career on. Did you have your psychologist involved?
Yes, and we also had a peer-to-peer behavior. It was like a behavior companion as well within the facility, trying to help with different approaches for staff.
Mm-hmm. So did that psychologist, whoever train you, that whenever you're within 1 arm's length from this patient, you should hear a dump truck backing up, which goes like this: beep, beep, beep. Did they train you on that?
Not that I recall.
Yeah, usually not. And nurses and particularly nursing assistants have to work within that one arm length, right? People like me, I can stay a ways away, low probability of getting bit, scratched, hit. But if you, I can't do it on a Zoom, but I do a whole thing about how to position your body so you don't get bit, hit, or scratched. And, you know, I would write recommendations, make sure the fingernails are trimmed if they're scratching, putting on mittens before doing any cares, using an assistive tube, using a weighted blanket when doing certain cares. There are tons of things that can be done to decrease the probability of the negative outcome, scratch, bite, hit. The other would be to look at what's driving this. Is, I assume you ruled out any medical. Then I would want to look at what, there's no anti-scratching psychotropic medication or anti-screaming or anti-hitting medication. But sometimes that behavior is being driven by internal emotional distress. And that's how I train staff to avoid problems in a courtroom or regulatory. You aren't treating the scratching, you aren't treating the screaming or biting, you're treating the internal emotional distress as evidenced by screaming, biting, etc. Sometimes getting to the right dose. Now, this takes us to another problem. I don't know if this is true in all your homes, but it's true in a lot in the Twin Cities. Much of the care now is being provided by relatively young, pretty inexperienced nurse practitioners or PAs. The old adage in psychotropics, and remember, I started my career before OBRA, before October 1st, 1990, and I was on a national training team for 5 years on restraint reduction, side rails, mechanical, and chemical. But there are a lot of people that are really hurting on 12.5 milligrams of Seroquel. Well, in a clinic like ours, we often will use 400 for sleep. So the old adage is start low and go slow, but a lot of providers are starting low, going slow, and stopping. I encourage your team, if you get into psychotropics, measure it in the same way with the same sort of tenacity that you do with wound care. You know, where you put that plastic thing on there, is it getting bigger, the same, or smaller? You want to be doing that with your medication to see if you're getting a good outcome. The other thing on a case like this that I do, and it sounds like you have a mental health provider, but like this morning, I was at a nursing home. I got there at 6:30 or at 7:30, excuse me. And in the meeting was the administrator, the assistant administrator, the DON, ADON, director of social service, director of TR, all the clinical nurse managers. And I go there with myself and 3 of my team. And with that team, we talk about any new referrals. Let's say they want to refer Betty Doe, Johnny Doe, and Timmy Doe. But then all the people on my caseload, we discuss some of them briefly, and it might be just fine. And we all sign off on it. And I'm there every week with my team. So there's 52 sign-offs in a year. So when the health department says, what are you doing to improve the behavioral health of your residents? You can show them that. And what are you doing to improve the behavioral competence of your staff? You can show them that, because we have a section on there, themes discussed. And like this morning, I did a little talk, went 5 minutes on the difference between obsessive compulsive personality disorder and obsessive compulsive disorder. And often I will do that. But that way you're keeping that resident, just like somebody with severe wound, like I know any deal, I think there's some DONs on this, but know exactly who has wounds in their building and which ones are getting better, worse, or the same. You want to have that. You want to identify who are your polar bears and make sure they're being reviewed, on a regular basis. All right. I hope that was helpful.
Yes, thank you.
What are some interventions that can be used with sexual remarks and attempting to touch staff? That there's multiple things in Miss Caroline's comment, but just wondering how you teach staff confidence and ability to handle some of these and demonstrate interventions that can assist them.
Yeah. I'll get to that. Somebody had just, these things popping up here in these chats said something about psychotropics. Believe me, I understand that much better than most, and because of what I told you earlier. I'm not anti-medication. I'm not pro-medication. I am all on board for appropriate use of medication. So what you always want to go with non-pharmacological interventions for quite some time before you go to medication. So what are some interventions? One is to make sure that let's say not every one of your residents are making sexual comments, right? So it's usually one or two people at a time, and making sure all staff have been trained proactively on sticks and stones may break your bones, but sexual innuendo won't kill you, or you can use your own way of doing that. And why is this important? I've been involved, I believe, in 3 cases in my career where somebody grabbed somebody's breast or said, "Hey, baby, I want to blank, blank, blank you." And the staff member punched him or hit him in the face. All of these ended up with a strong investigation, one of them in a lawsuit, but all of them had the hallmark of the questioning, what did you do with your staff before? Because all 3 of these, the patient was doing it at the beginning. So feel free to steal my metaphor about putting on your anti-personalization suit. That's a strategy. Number 2, if that resident was saying those same sexual statements to you in Chinese, would you react like you are? The staff member is going to tell you no. And why is that? Well, I don't know how to speak Chinese. In other words, you aren't personalizing it. Can you hear things like, "Hey, you're a kangaroo"? And they'll probably smile, and you can say, "You have an urge to jump?" And they're going to tell you no, because you didn't personalize it. So those are things you can do on the front end. Number 2, in terms of the statements, I don't think you're ever going to get away from it. But sometimes what we will do is run a behavior program and say, "Bob, for you not making these comments, I know you like Big Macs from McDonald's. If you go the next 3 days without any of these comments, we'll get you a Big Mac." Or other incentives for not doing the statements. And then on the grabbing breasts or buttocks or, crotch area, it goes back to what I was saying earlier, how you position yourself. An example, this isn't sexual, but a patient has their shoelace untied. They're sitting in a wheelchair. Have you ever seen a staff bend down and tie it for them, and the resident then pulls their hair? If they had had that resident lying down prior to tying the shoelace, there's no way that they could have pulled their hair. So body positioning, body mechanics, just like you train your staff in how to body mechanics of lifting patients off a toilet, out of bed, etc., you want to teach them emotional mechanics of how not to personalize things and how to position your body so that it doesn't happen. But I like talking about this on the front end.
Yeah.
It's going to happen.
Yeah, it definitely is. We're almost at our time. So before we go, I just want to give you guys, we want to thank Dr. Brose for coming and speaking on this. But before we conclude, I want to tell you about our next presentation, the Nursing Home Leadership Table. We'll be continuing our series on Wednesday, July 10th, 2024, where Jana Boughton will be our guest speaker, and we'll be diving deeper into the topic of F0607 and F0609, failure to report abuse and or neglect. Before you exit, please feel free to click the link in the evaluation chat box to provide us with feedback. The other thing I want to mention is that we have our immunization email address. If you're interested in a free mobile vaccination clinic, it's at immunization@superiorhealthqa.org. It is in the chat as well. I know you guys are all trying to get your residents up to date per the CDC and NHSN's guidelines, so we want to offer that as well. So please, thank you for attending. Thank you for speaking, Dr. Brose. This was a great topic, and we look forward to seeing you on July 10th. Have a great day, everyone.